What I try tonight, this evening, is to share with you some thoughts which are really coming out from one side, the recent evidence we have, how some drugs were so really and surprisingly effective in preventing cardiovascular disease in type 2 diabetes. Of course, I'm speaking about GLP-1 receptor agonists and SGLT2 inhibitors. And also, particularly for SGLT2, you know, we also have a strong evidence that they are so beneficial in preventing heart failure, or much better hospitalization for heart failure and nephropathy. So this amount of evidence led in time to build some new and more new guidelines. And we got, particularly at the end of the last year, two very important guidelines. One is the so-called consensus, or ADA-ESD consensus, related to how to manage, specifically dedicated to how to manage hyperglycemia in type 2 diabetes. And the other guidelines was coming out from a cooperation between the European Society of Cardiology and ESD. And these guidelines are more specific because they are approaching the problem of cardiovascular disease in diabetes and prediabetes, not only from treatment of hyperglycemia point of view, but of course is a very comprehensive approach, looking also at the thrombotic prevention and so on, being a guideline. I would like to clarify the concept of what means guideline and what means consensus. The process to develop a guideline is a very long, serious, tough process. We needed 3 years to build the guidelines. Why? Because you have several task forces with the expert of a specific aspect of the disease you want to touch. You search for the literature, then you go for grading according to the evidence and the level of evidence. The consensus is something else. Mainly is an opinion of experts, meaning that you have several, of course, great experts, but the process is completely different. It's not evidence-based. It's mainly a point of view of the expert. And if you pay attention to this, you find written very small characters that these represent not the official point of view of ADA or ESD, but mainly the opinion of the experts. So meaning that even the two societies endorse this consensus, they do not take the full responsibility of what is written. It's a little bit a paradox, but please, just read what is written. So this is so guidelines something, consensus something else. So in the ESC-ESD guidelines, there are some revised concepts. Of course, I will focus mainly on what is of interest for the diabetologists. And first of all, the most important approach is to change the classification of the risk, how to define somebody as risk. You see that these new guidelines are suggesting to consider 3 kinds of risk, meaning if you have somebody with diabetes, an established cardiovascular disease, or with a target organ damage, or 3 or more major risk factors, or early onset of a type 1, because of course we are so focused on type 2 that we forget that also type 1 pays a lot in terms of risk for cardiovascular disease. But in these guidelines, you see that if a type 1 with a long duration of disease, more than 20 years, you must consider this kind of people at very high risk for cardiovascular disease. If you have a patient with type 2 with diabetes with a duration over 10 years without target organ damage plus any other additional risk factor, this can be considered high risk. At moderate risk, we have younger patients in type 1 less than 35, type 2 less than 50, with diabetes duration less than years without other risk factors. So it's very complicated to have somebody at a moderate risk. Why we decide to adopt this approach? You know, there are several algorithms that you can use to calculate, in order to calculate the level of risk, cardiovascular risk. I think that I understand that in the 40-45 minutes you have for each patient, more or less. You have 45 minutes for each patient in your hospital, no? No? More or less. What I mean, when you want to calculate adopting an algorithm, you need time. You need the tool. So until you calculate the risk, your time is over. You say, okay, next time in 1 year, we will discuss what to do. So really, this means that this approach is more pragmatic. I think that just watching your patients, you can define, you can understand if at which level of risk it can be. No? It's not so complicated. So the idea was to simplify this kind of a phenotypization. And the most important recommendations were, according to the evidence, that regarding SGLT2 inhibitors, a GLP-1 receptor agonist, these classes of drugs are very effective in reducing cardiovascular risk, and please, in both with the people with diabetes and the previous cardiovascular event at very high risk. This was something new. In this guideline, for the first time, was introduced the concept that these drugs can be beneficial not only in people with already established cardiovascular disease, but also in people with diabetes at very high risk or high risk for cardiovascular disease. Please, class 1, level A, meaning the stronger, you cannot have something stronger than this. What about what to do to reduce the heart failure risk? Of course, we have a lot of evidence that SGLT2 is the class to prefer to prevent the risk for heart failure, class 1, level A. But because, of course, we have been accused that we have killed metformin in these guidelines, you know, you see that is not completely true. Metformin also has been rescued for the first time as a good option in people with heart failure. There is one trial showing that metformin can have some benefit in people with diabetes and heart failure. While, unfortunately, the evidence for GLP-1 receptor agonists is not present. So until now, even some recent meta-analysis suggests that probably there is an effect also for GLP-1 receptor agonists. This never came out in one single trial. About the chronic kidney disease, of course, ARB we did not discuss. They are very useful for kidney disease and diabetes, but also we have evidence particularly strong for SGLT2 inhibitors, but also for GLP-1, that they are also beneficial in reducing the risk for kidney disease. And this is the algorithm, the most very famous ESC-ESD algorithm, which for the first time suggests that if you have already somebody on metformin with the previous cardiovascular event or at high risk or very high risk for cardiovascular disease, then add a SGLT2 inhibitor or GLP-1 agonist. Otherwise, if there is no this, you can continue with the metformin, and if A1C is not at the target, go for another option. First, pay attention here. There is no indication that you have to use these drugs if A1C is not at the target. So the suggestion, the recommendation, this guideline was use these drugs independently from the level of A1C, because this way you can protect people from cardiovascular events. And this is the next steps. These are the next steps. What about the ADA-ESD algorithm? Also, okay, they make something very interesting, I have to admit, because they, for the first time, they differentiate more specifically if you have a predominant risk for cardiovascular events or heart failure or kidney disease, because in this case, you have two different options as a choice. If you have the high risk for cardiovascular disease means MACE, you remember MACE means the high risk for cardiovascular death, myocardial, non-fatal myocardial infarction, stroke. So a GLP-1 receptor agonist must be the first choice because the evidence is suggesting this. If you have somebody in whom heart failure of a chronic kidney disease is predominant, say, go for an SGLT2 as first choice. And then you go also in this consensus, if A1C is above the target and so on. But I wish to underline some statements you can find in this consensus that, based on the studies published thus far, we believe that for patients with type 2 diabetes and established atherosclerotic cardiovascular disease, such as those with prior myocardial infarction, ischemic stroke, unstable angina, ECG change, myocardial ischemia on imaging or stress tests, or revascularization of the coronary, carotid, or peripheral arteries, where MACE is the grievous threat, that the level of evidence for MACE benefit is great for GLP-1 receptor agonists. So this is really clear in the consensus. GLP-1 is the best option when you have somebody, honestly, in almost any kind of dangerous situation for cardiovascular disease. Of course, an SGLT2 must be the first choice when you have a risk for heart failure, particularly in those with reduced ejection fraction. We are still waiting for clear data on about people with preserved ejection fraction. There are some trials coming out, so we have to wait for this. But no doubt, when you have reduced ejection fraction, the SGLT2 should be the first choice. And also for CKD progression. And in all these situations, these drugs should be considered independently of a baseline A1C or individual A1C target. So in other words, the consensus and DSCC guidelines are releasing the same message when you have somebody with established cardiovascular disease or at a very high risk for cardiovascular disease. Where also what the problem is that reduced MACE GLP-1 can also consider in patients with established indicators of high risk specifically. And at this point, I disagree. Because I have to say, I'm not because I was in the board of the ASD guidelines, but I think that what we propose in terms of phenotyping patients is more practical than to see that you have to consider somebody in so-called primary prevention if he's 50 years older or older with coronary carotid lower extremity artery stenosis. So are too strict these criteria to identify somebody at high risk or low risk. And finally, and this is something new, they suggest that probably should be time to consider to start immediately with a combination instead of a step-to-step approach in managing hyperglycemia. But and these are my questions. There are 3 conditions when the start of the therapy in a drug-naive person is required, because the consensus just suggests, okay, somebody is drug-naive, then we will see, start with the metformin, and then go ahead, if A1C is not a target in this case, with a drug. Because of course, you can have somebody, you make the diagnosis, and this person is so lucky to have diabetes, but is not at high risk for cardiovascular disease. Or you make the diagnosis, and the person is already at risk for cardiovascular disease. He's hypertensive, dyslipidemic, and so on. So he's already at high risk. Or, and this was coming out in the board, because it's very nice to work with the cardiologist. What about somebody who has an acute cardiovascular event and then I discover diabetes? Do you suggest, this was a cardiologist in the board asking, please, do you suggest to start with the metformin in this case? He has a myocardial infarction, I discover diabetes, I have to start with the metformin. Why? And this is the problem, this is a dilemma, because again, also still in the new consensus, you find, okay, somebody with established cardiovascular disease, heart failure, you see here GLP-1s or SGLT2. But in somebody, drug naive, you still have the point, the suggestion to start with metformin. Let's see this story of metformin, because it's quite intriguing. From where is coming out that metformin should be the first line ever, first line therapy ever? First of all, there is this evidence from UK-PDS. I think you remember that in a subgroup of UK-PDS, let's say in 342 people, that if you compare with the recent trials, including thousands and thousands of patients, honestly, it's not so a big number. In these 342 patients, overweight patients, metformin significantly reduced myocardial infarction. And this evidence was consistent even in the follow-up. Pay attention, please. This is a pre-statin era. In the UK-PDS, people were not taking statin, so any intervention had more chance to be effective than today. What else? Nothing else. On the contrary, we have several meta-analyses showing a neutral effect of metformin on cardiovascular event in randomized clinical trials. Oh, there is only one meta-analysis suggesting a positive effect on metformin. But I have to say that this meta-analysis has been largely questioned. Why? Because it's pooling randomized clinical trials and daily clinical evidence that scientifically is completely incorrect. You cannot pool these two different evidence. Okay, so honestly, it's true, because the guidelines are based on evidence. The only evidence we have that metformin can help in reducing cardiovascular events is coming from the UK, a subgroup analysis of UK-PDS. While, if you look at these CVOT trials, the evidence, I think that you can agree, are stronger. The evidence is very, very strong. So, the board of the consensus, at least in the past, was raising this concern. And I think that you know this, what I'm going to share with you. Oh, but people in the CVOT trials were all on metformin. So metformin was the background therapy, so we don't know if these new drugs can work in the same way if metformin is not present. Correct? This is mainly the position of Melanie Davis, who is a nice lady, too British in my opinion, because it's very conservative, and the story is different. Because now we have evidence. This is coming has been published very recently from EMPA-REG outcome trial. And you see that when they evaluate the impact of the presence of metformin in the outcome, not only people without metformin had the same effect, received the same benefit from the empagliflozin in this case, but metformin was worsening the effect of SGLT2. And not only in the EMPA-REG, also in the canvas. So it seems that metformin in the background not only does not add, but probably is subtracting something from the benefit of these drugs. And this evidence, I'm sorry, I do not have the slide, was also coming out from Excel study using exenatide, has been published. So it seems that this story to have metformin as background to explain the benefit of this new drug does not work. The evidence is on the other way. And honestly, we had so many concerns, debates, enemies. I never was thinking, because the problem is that the diabetologists in the board of the guidelines were attacked, not the cardiologists, because, okay, they do not. But we were 5 diabetologists representing ESD, and all around the world we were attacked. Oh, God, we destroy metformin, our dear metformin. And because we proposed that, okay, in drug-naive patients, if somebody is at a very high risk, we have to start with an SGLT2 or GLP-1. Why? Because the evidence is in this way. We are not destroying metformin. On the contrary, we say A1C not at target, waiting for the results of the combination between an SGLT2 and GLP-1 receptor agonist, which is honestly very intriguing to see. At the moment, we say add metformin. We do not say forget metformin. Okay, but honestly, in the last years, we paid so much attention to the story of cardiovascular disease that it seems quite that A1C controlling hyperglycemia is not any more important. You give an SGLT2, you give an GLP-1, it's all. It's not completely true, because at least from the UK PDS, we learned that, okay, if you control hyperglycemia, you need a lot of time. You need almost 10, 20 years. But you have some benefit in reducing not only macro, but also macrovascular these complications. A phenomenon lasting in years, even in the follow-up of UK PDS, was treated at intensive way from the beginning. After 20 years, got some advantages compared to the less intensive treatment arm. Why? Because, of course, we were astonished some years ago because these trials were showing that if you control glycemia, you can kill your patient. You are too intensive, you kill your patients. Honestly, this has been revised because the concept is there is a huge difference between these trials. You know very well that in UK PDS, the disease, the diabetes was almost at the 0 time, meaning at the beginning, in the other trials, the disease had a very long duration, and you know the story of metabolic memory. What you do at the beginning of the disease lasts 4 years, even 30 years, and probably this explains the difference between the UK PDS and, for example, the VADT. In UK PDS, intensive control was started very early, and then the control of glycemia paid in terms of reducing cardiovascular events. For example, in the VADT, the intensive control, with also a lot of hypoglycemia, but this is another story, started after 11 years. What can you get after 11 years of worse, very bad control is to start suddenly to control hyperglycemia in a so strict way. Clearly, you get only peanuts, almost nothing. What is important is to start from the beginning to control glycemia. And Also, it's important because we have some meta-analysis. This is one that if you pull all the studies, we see ACCORD VADT, so what was available at that time, meaning in 2009, it's clear that good glycemic control, even in the secondary prevention, can contribute to reduce the risk for example, non-fatal myocardial infarction or coronary heart disease, not increasing the risk to die. So in other words, today, okay, we pay a lot of attention to cardiovascular disease risk, but we cannot forget the control of hyperglycemia. First of all, because I hope that with these new drugs we'll be also able to show a benefit on retinopathy, nephropathy, and neuropathy. Until now, particularly for retinopathy and neuropathy, we have only one bullet, the control of hyperglycemia, nothing else. So you cannot forget, because, okay, you spare myocardial infarction, and your patient is very happy. He was skipping a myocardial infarction, but he passed the life blinded. I don't know if it's better to have a myocardial infarction to survive and to have the possibility to see, you use your eyes to see what is around. So we have to, anyhow, to control also this. And also, if you already have a cardiovascular disease, it seems that anyhow, controlling hyperglycemia also pays. And this is why they were true. We need to get a good control as soon as possible. And you know that recently we got this evidence from this study, the VERIFY study, which is almost a proof of concept. This study was showing that if you start with the DPP-4 alone, vildagliptin, with metformin alone, or you combine and start with the combination of these two drugs, in 5 years, you get a better, you maintain a better glycemic control. So the proof of a concept was already coming out from small trials is that if you start with two drugs, instead of go step by step, you get a lot of advantages in years because the glycemic control lasts longer. Please, can I make a comment now? You know, I was raising the concept to treat hypertension immediately with a combination, because this is the usual approach today coming from the guidelines. Because the concept that time was, we have mainly two pathways involved in the pathogenesis of hypertension. It is much better to tackle the two, even with a lower dose of drug, than one, and then to add the second one, if not at the target, the blood pressure. Now, in diabetes, we have, at the moment, 8 different pathways involved. The frontal story, I think that you know. We have all 8 different pathways probably involved. And do we want to get the best tackling only one? Then we add the second one, third one, 8 with one drug. Honestly, it's quite complicated. And this is why recently we have suggested that probably the best option today, and this is coming out probably in the new guidelines, the best approach could be that the glucocentric view and the cardio-centric view can be harmonized. Meaning, in one way, you pay the best attention to control glycemia, not forgetting that you also can control the cardiovascular risk. How? Starting immediately with a combination. If there is no risk for cardiovascular disease, metformin plus anything else, because honestly, vildagliptin, in my opinion, was just a proof of a concept, is not the only drug that can be used in combination, but also the cardio-centric view. You can add a GLP-1 receptor agonist, particularly with a high risk for cardiovascular disease, on SGLT2, particularly if there is a high risk for nephropathy or heart failure. And in this way, you can control both glycemia and cardiovascular risk. Because anyhow, okay, you start with metformin. How long works? And then you lost 5 years to get another drug. So this is coming out. Probably we need some trials, but there is a lot of thinking in updating the guidelines that probably this could be the best approach in order to do our best to control both the glycemia and cardiovascular risk. Please also do not forget that these drugs, which are so good for cardiovascular prevention, are also very good to control glycemia, because in the last years, the risk is that we have forgotten this. They work very well in reducing glycemia. So why not use also to reduce glycemia, not only the cardiovascular risk? It's an extra benefit, but until the cardiologists will take these drugs for our ends, let's use them as much as we can. So in conclusion, but it's not my final conclusion, the cardiovascular disease is the leading cause of mortality in diabetes. However, we cannot forget how important it is also to avoid the microvascular complication of this disease, and how an early and continuous optimal glycemic control remains the best strategy. So it seems that it's time to harmonize both the gluco and the cardio-centric approach as the best strategy to reduce the burden of all the kind of complications of diabetes. I think this is very reasonable, but where is the problem? Look at the outcome of the guidelines. It's unbelievable. We have the same studies, and the different guidelines are suggesting a different approach. They give a different recommendation. And let me be a little bit provocative. Look at the most recent guidelines we got last year. We got the DSCC, American Heart Association, the SCC and EASD, this EASD, and the ADA-ESD consensus. But here, only cardiologists were involved. Here, only diabetologists were involved. These are the only guidelines in which both the specialists were involved. And probably this is a better approach, meaning that you need different specialties they have to cooperate. It was nice, honestly, to interact with cardiologists as well. It was nice to see how ignorant they are related to our many of our concept, and how we are ignorant regarding some cardiological aspects of the problem. So the interaction is the best. What is happening? Good news. We have this working group representing the most important scientific societies involved in the cardiovascular, diabetes, and nephrology, the European Society of Cardiology, American Heart Association, ADA, the Cardio Society of Nephrology, and so on, trying to harmonize the guidelines, because I think that the poor physicians, which guidelines do you want to follow? Which guidelines? If you are a diabetologist, you are very attracted by the ADA-SD. They are your peers, they are your partners. But if you are a cardiologist, you do not pay attention to this ... consensus. We are a cardiologist, we follow the European Society of Cardiologists, if you are an European cardiologist. If you are an American cardiologist, we follow the American Heart Association guidelines. At the end, the final result is a mess. The same evidence with the different recommendations. I think that it's a starting point, was very good starting point, because first of all, we try to understand which strategies can be common to all the the societies, because if you suppose that if you adopt the same strategies, the same criteria to interpret the evidence, at the end, you build recommendation very similar. So I think that, as I wrote recently, what is coming out in diabetes management at the moment is really an exciting confusion. And probably we really need to have a common view on how to use these wonderful new drugs. Honestly, I'm old when the dream of the diabetologist of my generation was to have something that can reduce glycemia and can reduce cardiovascular risk. Now we have, the problem is to use in the best way, to understand in whom and when and why to use any of these drugs. Thank you very much.
Thank you very much, Antonio. It's an outstanding and very complex point of view from inside. And now, if are there any comments or questions for Professor Ceriello? May I start with one short comment? According to you have presented the new assessment system for cardiovascular global risk. In my opinion, about 90% at least from our type 2 diabetic patients are included in high or very high risk categories. So if I well understood, you recommend for more than 90% of our patients the associations from the beginning between metformin and an SGLT2 or an GLP-1 receptor agonist.
Yes. Sorry, metformin today is so cheap that really you do not destroy your healthcare system if you use metformin in combination with something else. So in background you can use, and we have now the proof, because we had already of small trials showing that the combination is better, because honestly, we already have the proof, some small trials showing that if you start immediately combination of an SGLT2 metformin long term, but unfortunately long term in this trial was a year, you have a better outcome. If you associate metformin with GLP-1, you have a better outcome than if you use one of two drugs alone. So there were small trials that verifies a proof of concept. 5 years follow-up is a long period, no doubt. Why not? I told you, we have to follow the lesson of hypertension. They needed a lot of time to understand that probably it's better
or
to use...
Or cancer, maybe.
Exactly. Nobody is thinking to start now with one drug in these diseases, and we know that at least, I repeat, 8 pathways are involved in the pathogenesis of diabetes, and we want to tackle all with one drug. Unfortunately,
Ralph De Fronzo has this idea and recommendation about 10 years
he's using 3.
Yes.
Because in this way, all the companies are happy, because he has PIO, GLP-1, SGLT2. So.
And if our ideal patients maybe has an atherosclerotic cardiovascular disease and chronic kidney disease, do you think a combination between SGLT2 inhibitors and an GLP-1 receptor agonist?
We are honest, I'll say, ideally, I think yes. The story is that we are waiting, there are specific trials exploring this, is why you do not find at the moment in the guidelines, because again, guidelines are evidence-based. Until we need these trials, the outcome of these trials, but ideally, why not, honestly? Particularly today, 1 pill and 1 shot a week, no? 1 week a day, 1 pill a day, 1 shot, 1 injection a week. I think that your patient will be very happy instead to have several pills all together in the day and so on.
Okay, other questions or comments from the floor, please?
that risk quantification in high risk, very high risk and moderate risk refers mainly at the treatment of dyslipidemia in diabetes, in dyslipidemic patients, and cutoff points for LDL cholesterol. And the European guideline differs from the American guideline. Both are for 50%, at least 50% reduction in LDL cholesterol, but European guidelines are more strict and I think a little compulsive because they want to go down to 50 milligrams. And from 70 to 50 milligrams, you have to add another drug. Either ezetimibe, as the Americans say, or the Europeans say PCSK9 inhibitors, which is a little bit exaggerated, both from a financial point of view, but also medical, I think. Because I don't see any cardiologist who would prescribe a PCSK9 inhibitor to a high-risk patient with 60 milligrams percent LDL.
Of course, there was a specific task force in the board for the lipids management. I was involved for the story of being diabetologist mainly for this story of the new drugs and the management of hyperglycemia. On the other hand, when you speak about 50, 70, and also you know this story of blood pressure that every year is changing because new evidence is suggesting. Already I had the opportunity to discuss in another meeting, particularly with the cardiologist, about the story of guidelines. The guidelines represent a photo of the moment, of the evidence available at the moment. Maybe tomorrow you have a study showing that, okay, for the first 5 years, reducing LDL at 50 gives benefit. In 10 years, you kill people. It's a paradox. But any guidelines is based on the available evidence at the moment of when you build guidelines. This is another problem, sorry to jump in another question, of this working group, because you need really a very frequent update of guidelines. For example, the DSCC ESD guidelines, the last were released in 2013, and now we had 2019. 6 years for the medicine is an era, so we have a really change. About the story, if it's the case or not, 50 was coming out from studies. To get this, you need a treatment, particularly with the new drugs. Very expensive. This is a dilemma that never you can solve, because in ideal world, money should be not the problem if you have the best treatment. Okay, so is why, for example, I want to say this, because now we will get also IDF that was not, because they had internal issues, they were not joining the task to this group, but they will join now. The approach is, when you build a guideline, any guideline, you look at the evidence and then you say, okay, this is the evidence, this is the grading, stop. You do not pay attention to the economic aspect of the story. IDF, on the contrary, always paid attention to this, having guidelines settled for rich country, less rich country, and also setting the minimal that you can guarantee to the people. Because the minimal, for example, that for us should be not, easy to understand. The minimal is to get metformin and sulfonylureas, no? But for example, when Nambaya was the president of IDF in Cameroon, this was only for rich people. So everything is relative. What I mean, okay, you must differentiate between the evidence, the science. You cannot avoid to say, look, this is the evidence. If you are lucky, you have money, okay, you will live longer. This is the reality. Or if you don't have money, there are different targets. The minimum is this. But of course, nobody can say today, speaking honestly for the management of hyperglycemia, which is my field, that the combination of metformin plus sulfonylureas is better than the combination of metformin over the new drug. But also this they cost. But you cannot say because the evidence is there. Then somebody does not have money. It's very, very pity. I'm afraid about this, but this is a political issue. It's not a medical issue. You cannot say, what I mean, you cannot say, okay, because you cannot buy an SGLT2, you put a sulfonylureas is the same. It's not the same. As a doctor, as a scientist, as a physician, you have to say, this is the best. Somebody else has to understand how to cope with this problem.